we have new guidelines that are focusing on the triple elimination of HIV, syphilis, and hepatitis B. So the political leadership and environment at the national level, it's there, and that cannot go unsaid in terms of appreciating that environment that has really helped us as implementing partner to be able to program this area. But I think also we also need to acknowledge that with the PEPFAR program, despite all the success, we all know that the focus has been on a single disease. Has been on a single disease in terms of, if you look at the success that we have had on PEPFAR when it comes to the monitoring and evaluation system. We all know that it's great in PEPFAR. The accountability system is great. And when we come to the services themselves in HIV, it's so great. They're able to measure the metrics on where we are at the country level and where we want to go as far as the 95 are concerned. But the same woman in MNSH setting, when she goes for ANC services, she'll probably receive the better care in HIV. However, when it comes to syphilis, when it comes to other related MNSH need, they are not necessarily at the quality that we see in HIV program. And that's why this session is very important to be able to talk about the experiences and how can we really dismantle the disease-siloed approach to HIV care to adopt the holistic need for other needs of the mother, such as syphilis in that context, as well as hepatitis B and together with HIV. So just maybe lastly, before I end my note, I think it's very important again to reflect on the success for HIV, but also share the data and the concerning challenges that continue to exist to the siloed approach to HIV. The mother that attained ANC, if you look at the HIV testing in ANC, it's 90%, right? But if you look at syphilis testing, the coverage is still low. It's around 70%. If you look at hepatitis B testing, the coverage is, almost not there or even lower. So that's why we really wanted to bring this topic to the audience to be able to share the strategies that are going on at the higher level in terms of policies, of the policy environment, the guidelines, what is the ministry doing, but also at the implementation level, what has been the experience on integrated model of care for those diseases, but on the MNSH side as well, what has been the experiences of integrated maternal and neonatal child health strategy that has been very helpful in reduction of maternal mortality and child mortality as well. So with that being said, again, I once welcome you to this session, and feel free to spread the new knowledge, to contribute. We are all here to learn from one another, but of course also to learn from the panelists and the presenters, some of the experiences at the national level as well as the experiences from the field. Asante sana, karibu.
Thank you so much, Dr. Kimambo, for opening this session. And I would like to invite now our keynote speaker, which is Dr. Ahmed Makwani. He's the Director of the Reproductive, Maternal, Newborn, Child and Adolescent Health Services at the Ministry of Health. He's also a Senior Consultant in Obstetrics and Gynecology with over 25 years of experience. His expertise spans from the RMNCH policy, service delivery and surveillance, and he has led many initiatives to reduce maternal mortality and the guidelines and training manuals for the country. He holds a degree in medicine from University of Dar es Salaam, a master's degree from obstetrics and gynecology from MUHAS, and has extensive additional RMNCH training. So a big welcome to Dr. Makwani.
Good morning, everyone. Good morning. Good morning. Yes. My duty is so simple, just to introduce the topic and then move forward. First of all, we know that last year we released the DHS report, and you have heard from my predecessor speaker about the country profile in terms of reducing maternal mortality and child mortality. but there are issues still that needs to be attended. This is an issue of HIV. For example, if you look at the data on triple 95s, you will see that we are lagging behind in the first 95, whereby we are covering the population is 83% in terms of knowing the status. And we have made some progress in the second 95, which is 98%. And in terms of suppression, again, we are lagging behind, which is 94%. And this is a report from, which was published from the Tanzania Health Impact Survey. But when you look at the data from the ANC, you will see that the picture for 95, the first 95 is 98%, and the second 95 is 90%, while the third one we are lagging behind again, it is 90%. That is an area whereby we need to work together and see how best we can do so that we can improve the well-being of pregnant mothers. But again, this the newcomer. Is he or she coming with some infections or not? Again, you have heard from the previous speaker the issue of focusing on a single disease. I think this is high time we look forward to how we can include triple elimination, whereby HIV, hepatitis B, and syphilis are all considered equally, so that we have a better outcome as well of both maternal and the newborn. I would like to emphasize the point that this session, when we are holding it here, we are holding at a time when we are doing mid-term review. Mid-term review for both the health sector, strategic plan 5, the 1 plan 3, and other strategies, key strategies from the ministry. At the same time, we are working as a country to develop a new vision, a vision 2050. So whatever we are going to discuss here, they are likely going to put some more focus in those areas to see how much we can input in terms of midterm review, but also in terms of having a new document, which is the HSSP 6 and the 1 plan 4. Again, as a showcase success, all these issues need some kind of leadership. And this leadership is leadership as a country leadership, but also from the partner leadership. So that through the program of Afya Yangu, I hope we can work together and see the progress of the country in terms of triple elimination become realistic. Because currently we are like in a pilot. How much we can scale, this is an area which you will hear from the panelists here when they will be discussing. So without much ado, I would like to take this opportunity to thank the Afya Yangu group for organizing this session so that we can hear from the panelists in terms of various problematic areas we've covered, but where we can go. With those short remarks, I take this opportunity to take back the mic to you. Thank you.
Thank you so much, Dr. Makuani. Give him a big hand. Thank you. So, as you heard from Dr. Makuani, we are really talking about how we can integrate and utilize the RMNCH platform for other communicable diseases. And therefore, it's also a privilege to welcome our first presenter, Dr. Ukoma Nyamgata, will be presenting on behalf of the PMTCT unit of the Ministry of Health. Dr. Mkome is a medical doctor. He also has a medical degree in community health from MUHAS in Dar es Salaam. He has over 16 years of experience in the medical field, holding various positions ranging from clinical practice at a rural district hospital to be the medical officer in charge of a district hospital, being a DMO, and now that he's the head of the Strategic Information Unit within the PMTCT program of the Ministry of Health. Dr. Mukoma has been instrumental in programming the PMTCT interventions, monitoring and evaluation, and conducting various operational research in the field of reproductive, maternal, and child health services. So I welcome Dr. Mukoma to the stage for the first presentation on leveraging the maternal child health platform to address broader disease intervention and experiences from the triple elimination in Tanzania. Most welcome.
Good morning, ladies and gentlemen. Thank you, Roland, for the introduction. I'm going to share with you experience from Tanzania on acceleration towards the sustainable development goals and for maternal health and child mortality. I'm presenting this on behalf of Dr. Msangi, and actually this presentation will highlight some successes in leveraging on the maternal integrated rampant services and in triple elimination of HIV, syphilis, and hepatitis B from mother to child. Next. To begin with, going to highlight some findings from demographic and health surveys and also census on key indicators. Tanzania is home to 61.7 million people, as we all know from the census report released recently in 2022, where for every 100 females, there are 95 males, and the total fertility rate is 4.8. Skilled birth attendant is 85%, and maternal mortality ratio, as highlighted from previous speakers, has been reduced to 104 per 100,000 live births. Also, under 5 mortality is currently at 63%, 63 per 1,000 live births, and infant mortality 33 per 1,000 live births, and mortality is at 24 per 1,000 live births. So, as you look at these statistics, there is significant improvement in these key demographic, health indicators from the 2022 Tanzania Demographic Survey and Malaria Indicator Survey. Also, let's see trends in antenatal care coverage. Antenatal care coverage has been increased in the previous, has reduced to 90% from 98% between 2015 and 2022. Though there was a slight increase to 98% from 95% from the 2010 Tanzania Demographic Survey. NC4 plus visits increased to 65% from 38% in 2010, and also NC early booking has been increasing gradually from 13% to 34% in 2022. For childhood indicators, we have seen from the Tanzania Demographic Survey a decreasing trend on mortality indicators. Under 5 mortality has been decreasing, but also infant mortality has been decreasing, and the neonatal mortality has been decreasing gradually over the past 14 years. For HIV, we still see the prevalence of 4.4 for 15 plus and 3.8 for 15 to 14 population, with the with some regions indicate higher prevalences, especially the southern highland regions, like Njombe, Iringa, Mbeya, Songwe. Still the prevalence is very high, so similarly for the new infections. Next. Tanzania has been, the PMTC program has been evolving over the years, and the response towards EMTCT has been evolving from 2000 to date. And when the program started in 2000, we started with a vision of scaling up the services to at least all health facilities and all regions. Between 2000 and 2010, we were in a scale-up phase, and we scaled up the services. After developing the scale-up plan in 2008, we managed to scale up the services from up to 56%. By 2010, we were at 56% of the health facilities providing PMTC services. But today, we are talking of 96% facility coverage, which is a huge success in terms of ensuring access to PMTC services countrywide. After the scale-up, we embarked on adoption of global strategies for virtual elimination of mother-to-child transmission of HIV. And in 2011, we developed the first EMTC plan, which translated the global plan into country context. And this actually led the programming between 2012 to 2015. And we targeted to reduce the MTCT rate from 26%, which was there in 2011, to 4% in 2015. Despite we could not reach the target, but we made great progress. In 2015, actually, after the evaluation, we were at around 7.6%, and that was a great success. After 2015, there was a recommendation on integration of syphilis elimination in HIV programming. So we developed the second EMTC plan, which was for dual elimination of HIV and syphilis from maternal to child. And this second plan led the programming between 2018 and 2021. Despite the fact that we did not reach the expected targets, but it helped somehow increasing the uptake of syphilis screening. And it was in this period where we experienced the COVID pandemic, which also disrupted the supply chain of commodities, and we couldn't reach the syphilis screening targets. But then in 2022, we decided that we also adapted the global recommendations on triple elimination of vertical transmission of HIV, syphilis, and hepatitis C. So we developed the third EMTC operational plan, which integrates the three diseases and highlights interventions, strategies, and activities to undertake countrywide to ensure triple elimination of HIV, syphilis, and hepatitis C. So we are now working on that third EMTC operational plan, which is integrated, and on the triple EMTC operational plan, we have already developed the national guidelines on triple EMTCT, and also we have conducted quantification and forecasting of commodities needed to for the triple elimination, and also we did a feasibility phase of implementation of triple testing in 105 health facilities, and now we are starting scaling up. Scale up is being conducted in collaboration with PEPFAR implementing partners. We have up to now trained healthcare providers in more than 1,000 health facilities, more than 1,200 health facilities to conduct screening of HIV, syphilis, and hepatitis B. Next. Yeah, as I said earlier, screening of syphilis has been suboptimal. Screening uptake for syphilis has been suboptimal for the past 4 years. We have seen a stagnating coverage of syphilis screening within the ANC setting. But for HIV, as you can see from that graph, HIV screening uptake is up there at 98% for the past 4 years, of 98%. Even though we are using a single test strip for testing both HIV and syphilis, but the supply chain of the dual test kits has been a stumbling block towards achieving the high syphilis screening uptake. In 2023, only 86.8% of pregnant women attending ANC clinics were screened for syphilis, as compared to 98% of those screened for HIV. And the reason why we could go up to 86% from 64% between 2022 and 2023 was the recovering supply chain after the COVID-19 pandemic, and we managed to secure some test kits for the dual tests for HIV. EMT rate has also been declining in between 2014 and 2023. The EMT rate has been going down. In 2022, the EMT rate was around 6.9%, or close, you can say 7% in 2022. This is in accordance to the UNAIDS spectrum model outputs. Next. So in integrating the hepatitis B interventions into HIV programming, first we established the NASHCOP, the National AIDS, STIs, and Hepatitis B Control Program, which takes care of programming of the general population, the HIV, STIs, and Hepatitis B in the general population. Also, we developed the triple elimination operational plan, as I said, and we updated the integrated guidelines. We also piloted the rollout of HIV screening, hepatitis B virus screening in the ANC setting. And but for now, we still see some challenges, especially on funding for hepatitis B interventions. We do not have commodities, specifically hepatitis B virus DNA viral load laboratory reagents to screen, to test those who are hepatitis B positive to see if they are eligible for treatment or they should be initiated on prophylaxis to prevent vertical transmission. We also lack for hepatitis B immunoglobulin for for hepatitis B exposed infants born to women with the high viral load. And also we experience limited funding for monovalent vaccine, timely, which is also a key and important or crucial intervention to prevent vertical transmission of hepatitis B among newborns. And the delayed supply of the single tenofovir regimen, which is a regimen needed for prophylaxis or treatment of hepatitis B virus eligible hepatitis B infected eligible pregnant women. Next. So we have challenges with the funding, and as you can see, the lower graph there shows the amount of funds that we have, still very, very low as compared to the actual cost program. The second line is the actual cost for the program, and the upper is the cost as per strategic plan. So we are still having a funding gap, which is actually so huge to undertake these triple elimination interventions. Next. Next steps, we want to finalize the triple EMTC investment case, which is ongoing. Also, for this, we are developing scenario planning for funding with programmatic and operational efficiencies, advocacy for resource commitment, internal resource mobilization and external, and also to monitor the implementation. Next. Thank you.
Thank you, Dr. Mukome. Big hand for Dr. Mukome. And I know we are running a little bit behind, so we are quickly going to introduce the next presenter. Welcome Dr. Joseph Masenga. He is a public health specialist and medical doctor, currently serving as the Deputy Chief of Party for the USAID-funded Afya Yangu Mama na Mtoto project. He specialized in maternal and newborn health implementation science, focusing on research, capacity building, and policy translation. Welcome to the stage, Dr. Joseph Masenga.
Yeah. Thank you, Roland, and good morning all. I would like to take this opportunity to share with you, colleague, on the integration of the service along RMCH platform. So next slide. Next slide. Okay, so I just want to take you that we should look on the primary healthcare lens in terms of strengthening a primary healthcare system to deliver quality RMC service. So for Afya also we take into consideration of the primary healthcare component. So the first component is on service delivery, and here we are strengthening the maternal newborn health service along the continuum of care, focusing on antenatal, labor delivery, and postnatal. But also we know that having a comprehensive package for IMO at the lower level, like health center, is also very important to save life, and also looking on the comprehensive care for child health, where we also include case management for childhood illness, nutrition and immunization service, using the Reach Every Child approach to ensure every child is reached with immunization. But also we have another service delivery component for adolescents, family planning, integration along the MNH component, including antenatal, specifically for counseling, labor delivery, postnatal, also counseling and service provision. But also, without forgetting clients who are getting abortion complication, also integrated family planning, along also the care and treatment clinics. So on the other component for primary health care lens is looking on how we build the capacity of the health care to provide the quality services. So this is through blended learning, which actually including on-the-job training, coupled with mentorship, peer-to-peer practice for continuous practice, but also the e-learning as well as the integrated support supervision to continue improve provider performance. But to do this, we usually do what we call have a spoke model, where we use the mentors from the higher level facility. For us, we are using zonal hospital and Uganda, but also regional referral hospital, for them to be able to cascade the capacity building activities at the lower level. But as you know, primary health care is also making sure community intervention are also well integrate. So one component is community health worker, giving them the capacity and also to use the available tool for us. In mainland, we are using a unified community system for them to be able to provide services at the community level, providing referral and document the finding. The other component for primary health care, we are also looking in terms of data, health information management system, which actually we focus on the data management, and the capacity is actually built at different levels for regional, RHMT, district level, for CHMT, but most importantly for healthcare providers, health facility. And actually we are focusing how they document the information for service provision on the correct respective register, but also how they analyze the information for them to make a decision. But we also ensure other components for primary health care also taking care of availability of the commodities, health financing, as well as the leadership, which is key in terms of ensuring coordination and implementation of the integrated service is in order. Next slide. Yeah, so this slide is just to highlight that when we are considering the disease integration, we should also consider alignment with 4 pillars of the WHO for disease, for triple elimination. So looking at the primary prevention, infectious transmission, sexual reproductive health and linkage for integration, EMTCT, and infant child and partner services. Next slide. So looking on our integration mentorship approach, so we use different platforms to be able to integrate services. So for us, maternal newborn health, which actually, as I said, is along the continuum of care. So in this, we also have an opportunity to be able to integrate postpartum family planning on ANCs, actually including the counseling, but during childbirth and postnatal, it's also counseling and also service provision. As we all know, the postpartum family planning is one of the components for postnatal. Service as part of the integration, but don't forget gender is very, very key to ensure service providers align, to be able to adhere with the gender specific care principle to provide dignified care. Also, SRH are also integrated in service, but using the SRH platform for our project, we are also being able to provide other services like family planning, HPV vaccine, because this is a good participant for HPV vaccine, but also disease integration, HIV testing, and nutrition. We have also family planning platform. We also use this platform to offer immunization, nutrition specific growth monitoring services as integrated services. Next slide. Yeah, so at the community level, we have a different platform as well for family planning outreach at the community level. So this platform is also being used to integrate other services like nutrition. So in this aspect, we are also the mother who came for family planning, but they help their children for being assessed for nutrition. Also the ANC using this platform in primary, postnatal care. For nutrition at a community level, AFRIANG is also using Village Health and Nutrition Day platform. Also in this area, we are also able to integrate the nutrition itself for children assessment for nutrition status, and those who are found with nutrition being required for this facility. But also this platform is also used for immunization, family planning, ANC, postnatal, and child development. We also have immunization outreach using the Reach Every Child with immunization to ensure every child is reached with immunization service, but also these children are offered nutrition service. The mothers also are offered with planning services. Next slide. Yeah, so for disease integration, previous speakers spoke. TRH platform where we use girls mentors and youth health champion at community level, provide health education, and also provide an opportunity for referral for HIV, STI screening, and other needed services. For community, as I said, we have referral for HIV, TB screening, and other service based on the needs from the community. Next. So we have some success looking on the integration of the RMCH services. You can see from the policy level currently, the Ministry of Health, a lot of strategic documents, as you see, now have included integration of the service to provide clear guidance to healthcare providers at facility level, how they can offer an integrated service. But at regional level now we see the CCHP planning, including integration of the services, integration of the supervision from the RHMT and the CHMT, and also at facility level we have seen the provider providing service in integration model, but also we are able to see improvement of the RMCH indicators, as well as linkage of the client to specific care. As I said earlier, also we at community level, we now be able to implement different integrated outreach services for family planning, immunization, nutrition, and now also community health worker who have been trained in different package. They can offer a wide range of health promotion currently for nutrition, immunization, and also some MNH aspect like early booking for ANC, completing the required ANC visit, postnatal care, but also delivering as a health facility. Also for girls mentor and youth health champion as our agent at the community level, to also offer health education for youngs, adolescents, and also being given the opportunity for referral to seek for care at the health facility. Next. So this is just to share with you some of the results from integration of the services. So just looking on the Villages Nutrition Day platform, you can see more than 200,000 under 5 got an opportunity to be assessed for nutrition status, and around 0.7% found to have malnutrition, severe acute malnutrition, and being referred as a facility for treatment. But this platform for Village Nutrition Day, you can see over 5,000 client women received family planning, 300 received cervical cancer screening. For children, also more than 40,000 clients were able to receive immunization service and other services, as you can see. So just to clearly give you a picture that you can have a platform which can offer other range of the service, which is key as an opportunity for clients to access different range of the services. Next. Yeah. So for ACRH as well, you can see, so this using our girls mentor and UCS champion at community level, through different scheduled clubs at health facilities, they provide health education, and then those who are found with the need, they given a referral to the health facility. As you can see, 84% of the referral were completed. The completed referral means they reached the health facility and the feedback came back to the girls mentor. And those on the right side, you can see the reason for referral for this client. Next. So looking, this is just to highlight some challenges on the integration model. So we have some challenge in terms of leadership. And specifically here, I want to stress in terms of capacity of the health facility in charges, how they can manage the resources to ensure integration is being implemented at this facility, but also some of the challenge we all know, but I want to highlight that the staff rotation, for those who have been able to receive the capacity building, the rotation or transfer is also hampers the sustainability of the service provision. In terms of documentation, just want to stress in terms of multiple HMS tool. This is, of course, overburden for healthcare provider with paperwork, a provider with different register, and most of our HMS register actually don't provide an opportunity for integrated services. Next. So this just opportunity that program can take into consideration, specifically if we are talking of the integration. So we have triple elimination as part of the area. We can use RMCH platform for triple elimination, but also reproductive cancer, imaging threat currently for global health supply, global health security, and then also issue of data use. Thank you very much.
Good. Thank you, Dr. Joseph Masenga. Give him a big round of applause. Yeah, so we have seen from the two presentations, first on the successes that we have made in PMTCT for the elimination of mother-to-child transmission of HIV, but how we are moving towards integrating other diseases like syphilis and the need for hepatitis B, and the last presentation on the PHC lens within the MNCH platform. So I would like now to welcome our three panelists to further discuss what they see as the opportunities to further integrate communicable diseases within the RMNCH platform. So I would like to welcome to the stage Dr. Mzee Nasoro as our first panelist. He's the Acting Assistant Director of Reproductive and Maternal Health at the Ministry of Health. He's also a consultant obstetrician and gynecologist and has led the efforts to improve maternal health services. He previously served as the medical officer in charge of the Dodoma Regional Hospital, and he is also a certified national trainer for the emergency obstetric and neonatal care. He is also an obstetric fistula surgeon and holds an advanced degree. Welcome, Dr. Mzee Nasoro. Thank you. Our second panelist is Emmanuel Tluwai. Dr. Emmanuel is a medical doctor also with experience in obstetrics and gynecology and holds a master's in public health. He leads the USAID Tanzania's family health team and manages maternal, newborn and child health programs. He also oversees the USAID Afya Yangu Mama na Mtoto program, and he has extensive experience in clinical practice and program management with a background within the NGO world and the Tanzania government. Welcome, Dr. Tluwai. And our last panelist is Dr. Catherine Nko. Dr. Catherine Nko is also a doctor by profession. She has been working with the Elizabeth Glaser Pediatric AIDS Foundation in various positions and currently holds the position as the Senior Technical Advisor for PMTCT services and HIV testing services. She is also the Secretariat within the Global Alliance to End AIDS in Children by 2030, working together with the Ministry of Health, the PMTCT Technical Working Group. Welcome, Dr. Catherine Nko. So, as I was already saying, you're all sitting quite far apart, many chairs, but thank you for being in this panel, and I would like to start with Dr. Mzee. We have seen that the government of Tanzania has made really great progress in addressing maternal mortality. I think one of the biggest successes of Tanzania is to really reduce that from over 700 to now just over 100 per 100,000. So Dr. Mzee, what are the successes behind that? And could you describe those lessons learned and how those can be used now also to introduce and integrate other communicable diseases within the RMNCH platform?
Asante sana, Roland. Thank you very much. Good morning, all. And thank you for that very nice question. As a country, when we reached that number, as you are saying, that we reduced the maternal mortality in a short span of time from 556 per 100,000 live births to 104 per 100,000 live births. Everybody was surprised. But I would like to take you back. These efforts started earlier in the previous phase governments. And, we launched one plan during the fourth phase government, but the results during the era of MDGs was not very promising. We went from 578 maternal mortality, that was 578 per 100,000 live births, and then we came down to 424, I think, per 100,000 live births, and then we went back to 556 per per 100,000 live births. And what was missing there? You see, there was leadership. We were aspiring to get to the MDG targets, but what was missing actually was accountability. And that accountability was addressed from the fifth phase government when the current president, our Honorable Dr. Samia Suluhu Hassan, was the vice president. That is when she launched an accountability platform with the RCs. I think you remember, if you remember it very well, there was somebody who said that if somebody messes with a woman's health, they'll deal with that person very seriously, and use this word, tutashuka naye mzima mzima, something like that, if you can remember it. So at that time, that is when the sense of accountability was instilled in the regional leaders to take care of the women who were delivering in their places, as well as the health of the newborn babies. So that initiative actually was the game changer towards reaching our goals. And from there, the regional commissioners took that spirit down to the technical arm. These are the RMOs, the regional medical officers, down to the district medical officers, down to the facilities. In this phase, we had strengthened the MPDCR, because that is the guideline that we are using to monitor, maternal mortality and newborn mortality. That is maternal and perinatal death surveillance and response. We were doing that in the past, but after that launching, we strengthened the response part, the response. We are doing the maternal and perinatal death surveillance, but the response was not very strong. So we took an initiative of strengthening that response part by encouraging the facilities, the CHMTs, the RHMTs to have appropriate plans to answer the question as to why had that death occurred. The causes of death, we know them: hemorrhage, hypertensive disorders, and such things. Having knowing them, we think we are in a position to either prevent them or to manage them so that we can save the women's lives and the children's life. But I think that part was missing. So we encouraged them to go more to the response part than to discuss about the associated factors as to why this death has occurred, and make an appropriate action plan. And that came up with another invention. We leveraged on the social platforms to create a Zoom MPDCR platform that is discussed countrywide, and everybody who is taking care of the women and children can participate and share their view. So when we discuss these cases of the women who have died, of the newborns who have died, we get a lot of ideas from the other professionals on the platform that is being conducted countrywide. And the chairperson, those who are involved in conducting these platforms, actually are coming from the professional organizations such as Agota, TAMA, and SATA. These are the organizations which deal with the maternal and newborn child health. So they are directly involved. And when we realize that there are gaps which need to be addressed, we also have a same platform through the Zoom, the same Zoom. So in this way, we identify the gaps, and we form a solution to the gaps. And if it is capacity building, we use the platform, to train and to train the healthcare providers on interventions that can reduce such occurrence in the future. So this has been very helpful, but on top of that, the government has invested a lot in constructing health facilities. In general, there's a tremendous increased number of health facilities, and then has helped in accessing the services. Currently, 80% of the Tanzanians can get to health facility within 5 kilometers. And to add on that, we have also established and constructed a lot of CEMOC facilities. These are comprehensive emergency obstetric and newborn care facilities. Our target come 2025, according to One Plan 3, is to have about 80% of the health centers providing CEMOC services. Currently, we are about over 60% of health centers are providing CEMOC services. So these are the things that have been implemented, and that has made us, come up with that number. We've reduced the mortality at a very fast rate, and everybody's surprised because we have the leadership, the higher leadership, and the accountability, and the will. Actually, the will of those people who are, responsible for taking care of the women's health. But there's one thing that is coincidental. We know that in developed countries or high-income countries, maternal and newborn mortality is very low. So there is an association between the economic development and maternal and newborn death. Our country has graduated to lower middle income country, and I think that is coincidental that the economy is improving and the maternal mortality ratios are decreasing. So that could be a direct association, and we know that with improving economic situation, we're also going to reduce maternal death and newborn death even more. So how are we going to use this experience to integrate other services in the RCH clinics? As it has already been presented here by my colleagues, what they've presented is what we are doing. At the ministry level, we have integrated the NASIP and the sexual transmitted infections programs into one. Now we have NASHCOP. That is one of the responses of integrating the services. We know that an antenatal clinic is an entry point for women into healthy system. So we are going to use that opportunity to look at the lady holistically, not just taking care of the pregnancy, but also taking care in other communicable diseases, such as has been mentioned here. We screen the women for malaria, TB, HIV, syphilis, and now we've come with hepatitis B. So all these services will be, actually they are being provided at one place that is very convenient for the woman and the newborn babies or the fetus. In the case of obstetrician, we want to prevent MCT, mother to child transmission, of all those infectious diseases. It is ideal for them to be available at one stop. It is appropriate for the lady, and it is also appropriate for the government, given the scarcity of human resource for health, as it was presented here. So we are going to optimize the human resource for health to look at this patient or this lady holistically, not let her go from one place to another. So that is as you have forwarded the question to me, that is what we did to reduce maternal and newborn mortality at this very fast rate and become an example in Africa and in the world at large. Thank you very much, Roland.
Thank you so much, Dr. Mzee, for a very elaborate answer, and indeed highlighting the importance of holding people accountable and really bringing that down, that accountability matrix, using data to review the progress to make that success, and also highlighting that a one-stop shop approach will really work. Before I actually move to Dr. Trouai for his question, and I know we are running out of time, I would like to recognize the presence of Dr. Faustine de Goulile. We are most honored to have you in this symposium to attend us, and again, also congratulations with your appointment as the regional representative for Africa at the WHO. Most welcome, Doctor. So, Dr. Trouai, we heard from the government perspective on the successes, and we would like to hear from the donors' perspective as well. What do you see on how donors like the US government and different entities can support the integration of communicable diseases within the RMNCH platform. Maybe pass on the mic. Thank you.
Thank you very much, Roland, for the good question. Good morning, everyone. Yeah, so, first, I have to congratulate what Dr. Mzee said, and through him, the government of Tanzania, to all the achievement that you have reached so far. Well, you have really highlighted how, as a country, we have reduced maternal mortality, a decreasing trend as far as child and neonatal mortality for the country, as per the DHS 2022. A lot of gains from different fronts. We really congratulate the government of Tanzania, but also setting a conducive stage for donors or rather developing partners. I think that is more politically correct to operate and to complement what the government of Tanzania is doing is really commendable. Just to highlight establishment of NASHCOP to support or rather set a stage for elimination of for triple elimination initiative here in Tanzania. Of course, developing guidelines and everything, I think that creates a conducive environment for developing partners to chip in and complement what government of Tanzania is doing. So talking about developing partners and the resources gap that NASHCOP team presented, you have, I cannot avoid talking about resources. And charity starts at home. So I'll start to highlight what USAID is doing to complement government of Tanzania efforts toward triple elimination. So historically, USAID have been a good partner to government of Tanzania, going back to, like 60 years back. And if I scan quickly, I cannot see possibly one or two with age 60 years. So it's way long before possibly most of us who are participating in this forum, we were not born possibly. So it's a long time ago and it's very historical. So our support for past 60 years possibly will continue, we hope so. But I wish to highlight some of the things or areas that currently USAID is supporting the government of Tanzania, especially towards the triple elimination angle. So the examples of Afya Yangus, there are 3 Afya Yangus: Afya Yangu Southern, Northern, and Afya Yangu Mama na Mtoto. We had, for instance, the presentation from Dr. Joseph as far as Afya Yangu Mama na Mtoto is concerned. We are supporting quality of care in the continuum of RMNCH services. And that starts at the time of preconception, before conception. Issues like family planning were mentioned here. ANC, labor and delivery, postnatal, child health, immunization, to mention the few. And I wish to highlight one angle at ANC because that is a really critical point where if we want to eliminate, meaning to reach triple elimination, we really need to capitalize more. So ANC is one of the areas that we are really supporting to make sure that pregnant women here in Tanzania receive quality services. Under HIV, vertical transmission of HIV, thanks to PEPFAR support as well. That is the area that USAID is hugely contributing towards supporting triple elimination, especially on HIV, as far as vertical transmission is concerned. Critical to our mechanisms is innovation and integration of services to make sure that there are no missed opportunities, especially for women of reproductive age. And as you can tell during earlier presentation, innovation, integration is really critical. And overall, to address comprehensively the need of women of reproductive age, if at all we need to achieve triple elimination. So we are doing that thanks to the conducive environment and collaboration we are getting from government of Tanzania and Zanzibar as well. Our coverage is really wide to several regions of Tanzania. And I was a bit keen this morning to see from our end, USAID, what we are doing to support hepatitis B elimination as well. As NASHCOP colleague mentioned, that is the area that still more support is needed. So I learned that we are also procuring a test kit for RCH use as far as screening for hepatitis B is concerned. Though there are a lot of areas that need to continue to support, but that comes to, it goes to my second point of developing partners and entire donors community to collaborate towards ensuring that we eliminate triple elimination by 2030. And I'm mentioning 2030 specifically, and I'm glad we have Dr. Ndugulile among us. WHO talked about elimination by 2030. So really wish to hear later on if at all we are eliminating as a country by 2030 or not, because we have to set a target as well. So it's triple elimination by 2030. That's huge. It's 6 years from now, possibly 5, because we are in October already. So with around 5 years of eliminating HIV, vertical transmission, syphilis, and hepatitis B, resources is really critical. So it's really a high time all developing partners to join hands with government of Tanzania to see how we can jointly achieve triple elimination, especially coming 2030. We have only 5 years. It's not long time. But donor communities, they will possibly agree with me. Funding is keeping on to be, or other resources in general, keeps to be a scarce resource. As far as resources are concerned, there are some developing partners. Their resources are kind of possibly the same, but more restrictive towards what area to invest and support. And the other thing is in some donors over years, they've remained with almost the same budget in supporting countries like Tanzania, while the need is keeping on increasing. For instance, if we have 10 million supporting Tanzania 2012, when the census shows that we have around 47 million, you cannot use or effectively or impactfully use the same fund coming 2022, where the census shows we are around 61.7 million. So again, that is the challenge where I see from donors. But regardless of these challenges, we have triple elimination to achieve coming 2030. Let us dig deeper into our pockets to see how much we can complement government efforts. On the same note, for sustainability, we really need government of Tanzania to also allocate more resources towards triple elimination. And this is for sustainability purposes, but also to sustain the gain beyond 2030. Thank you. Wish to hand it over back to you.
Yes, thank you, Dr. Tluwai. Thank you. Yes, Pigamakofi. Thank you for highlighting and emphasizing indeed that resources are needed, and we saw it from the presentation. There's a big gap between the actual needs for the implementation and the available resources, and that domestic resource mobilization is important. You highlighted the ANC as the main entry point, and I think also the presentation showed that even in ANC, we still have the challenges of late booking, and only 65% of the women actually make it to 4 antenatal visits. So these are areas that still need attention. And thank you for highlighting that eliminating HIV is not the only target by 2030, but it is the triple elimination, and syphilis and hepatitis B are included. So that brings me to our last, as Dr. Nko, Dr. Catherine. You as an implementer working for USAID Afya Yangu, you have been really supporting the regions, the councils and the district health facilities to build their capacity to integrate. You see as the remaining needs to make this integration, focusing on triple elimination, happen. Over to you.
Thank you, Roland. So the fun part about being the last speaker is that most of the things have been said by the great minds that have spoken before me. So to start with, I would like to in the efforts towards achieving triple elimination, I would like to commend the government of Tanzania on the great work that they have done so far as expanding the coverage of PMTCT services is concerned. From the presentation that we had from the PMTCT unit official, we saw that the services have been expanded, and according to the annual report of 2023, we see that 96% of all facilities offering RCH services also provide PMTCT services under the same roof. But I would also like to commend the efforts by the government of Tanzania in collaboration with development partners on the capacity building efforts. We see that we have strategic plans, operational plans, guidelines in place, commitment from the government as far as the Global Alliance to End AIDS in Children is concerned. These all speak to the commitment that we have towards achieving triple elimination. And there's also expansion, as the first speaker, Dr. Makwani, said that this is high time when we really need to expand our interventions in preventing vertical transmission to include syphilis and hepatitis B. So we see that we have a strong foundation that has been laid over time with the PMTCT efforts that were made towards reducing maternal mother-to-child transmission of HIV. So we have a platform to build upon with several learnings and several mistakes that we did before that have been rectified to make sure that we really achieve this goal that we have. So expanding to include syphilis and to include hepatitis B, in addition to the HIV that we have already been doing over time, is something that is really crucial and something that we have an upper hand with, because at the moment we already have systems in place to monitor the implementation and to understand the learnings that we get from implementation on the ground. Despite all these major efforts that have been done, all this commendable job that has been done, there are still some challenges with our strategic information issues that we have. For example, looking at the PMTCT cascade, we have several tools that need to be documented into and that need to be referred to so as to kind of measure ourselves where we are with prevention of mother-to-child transmission. The HMIS tools from ANC, it's different from the one used in labor and delivery, different from the one using in postnatal care, and even different for with the mother-child cohort register that helps us in following and monitoring the mother-baby pairs throughout the care in the PMTCT fight. So this kind of gives chances to documentation challenges and human errors as far as report compilation is done. However, one thing that we have really seen that has been useful is the introduction of the digital platform, the Unified Community System, which has already been mentioned by one of our colleagues, an electronic medical record system that allows for a longitudinal follow-up of this woman from the time of pregnancy, the delivery, even the postnatal period, including the follow-up until the child graduates from the PMTCT services. This is not only reporting tool, but it's also a very useful tool in the sense that it is a decision support tool. So it you kind of kill two birds with one stone. You have proper documentation that is guaranteed, but you also have decision support for the human resource that we are seeing right now that is being challenged with, according to the presentation that our colleague did, Dr. Joseph. So you find that with the rollout of the monitoring, electronic monitoring system, the unified community system, it is a tool that is going to help us in ensuring that we have quality data that allows us to monitor the implementation of services at the ground level. At the same time, I still see an opportunity to further improve the use of the unified community system by expanding it to include all the 3 conditions, HIV, syphilis, and hepatitis B, and therefore enabling us to be informed in a timely manner for appropriate decision making. So, in a nutshell, I am not saying that UCS is a magic bullet that is going to get rid of everything, every problem that we face, but it is very well close to that, because at least we will be informed in a timely manner to make decisions that can enable us to address them in time in this era of shrinking resource pool. So, what am I saying as far as what needs to be done to improve these challenges towards reaching elimination? I believe a proper documentation system such as a unified community system will be of great help. Thank you.
Thank you so much, Dr. Nko. Yes, and thank you for highlighting indeed that digital solutions, whether it's a unified community system, will help us to have better access to data, and will also help us, as Dr. Mzee already highlighted, hold people accountable. You need the data for that, and I think the PMTCT services or the MNCA services for many years have been relying on the Matuha tools, paper-based tools. And I think we have learned from the HIV program, even from the TB program, that digitizing the data is not only helping decision making, but it's also helping the healthcare providers to reduce their burden of reporting and recording, and helping them also to make decisions based on data. So I really would like to thank our panelists. I know that we are really running at the end of the hour of this session. We wanted to open it for questions and answers if you have, but looking also at the time, maybe 1 or 2. If people want, they can raise their hand for 1 or 2. I see 2 raising their hand. So if we can get that microphone to those 2 people for really short 1-minute questions to the panelists, and then we'll call Dr. Alice Christensen to wrap up this session.
Good morning, everyone. My name is Vanessa Paul, DDS student from UDism. I have one question to Dr. Mzee. I have been researching on family planning, and the current situation in Tanzania in Mbeya actually shows that the knowledge is actually high, but the attitude and practice are really low, and this has an impact in unsafe abortion. So you have talked about maternal mortality rate. I would like to know from your end, what is the actual situation? Where are we in abortion, and how much percent or to how many folds does unsafe abortion contribute to maternal and child health? And also from your end, how would you talk about family planning? Because I believe if we strengthen family planning and attitude and practice, we will come to the end of unsafe abortion, and that can contribute very much to reduction of maternal and child mortality rate. Thank you.
Thank you so much. And we saw one hand in the back for the second question, and then we'll give the floor to answer.
Thank you very much. Dr. Ambrose Katunji. I serve at Wekea Solar. I have 2 questions to Dr. Mzee. One is we've observed utilization improvement across several countries in sub-Saharan Africa, but then the reductions in maternal mortality is still not significant, and the issues around the quality of care. So how has Tanzania addressed the quality of care for services? And then my second question is around we are aware that reducing maternal mortality is not an issue of Ministry of Health only, because there are multiple sectors involved, including agriculture, education, issues of teenage pregnancies, access of family planning, but to the teenagers who contribute significantly. How has the Ministry of Health and the government involved other sector players in addressing this, because we might hit a plateau at some point. And then finally, I would like to invite you to a health facility electrification forum tomorrow here at about 9 a.m., which will be looking at the role of energy in improving healthcare. Thank you very much.
Thank you so much. 3 questions, all for Dr. Mzee, so please try to be succinct.
Yeah, thank you very much for the question. I'm happy that there's been a very interesting topic that has several questions. One, family planning. It has been shown that if you improve family planning uptake, you reduce maternal mortality. But unfortunately, modern contraceptive uptake in our country, as you know, in the HS 2022, is still very low. And the abortions are still there. But in this audience, if there's somebody who has been practicing for a long time like me, the cases, if you go to the health facilities, the cases of abortions that you are seeing nowadays, it's not like the cases we used to see. People nowadays are not doing, the physical or using instrument. They use other things else. We know that. But we are not denying that abortion is still a problem. And we can counter the problem of abortion by, improving in family planning. But we have a problem with family planning, with myths and misconceptions are still there in our African society. So we have to still work on advocating for people to plan their pregnancies, not to get unplanned pregnancies. As the Ministry of Health and as a country, as the health sector, we are providing comprehensive post-abortion care up to this time. So we take care of those who have an abortion. We are also we are also providing the family planning education and the methods after taking care of their complications. So that one we are doing. So abortion is still there, but we need a concerted effort to reduce the number of abortion and to bring up the modern contraceptive prevalence in this country. And the other question was about utilization of the health care. A number of women who are being attended by skilled health professional during delivery has gone up. It is about, I think, more than 80%. So utilization is very high in maternal newborn child health. And if you remember, at one time the president said that we have built a lot of facilities, now we need to improve their care. So we are in the same thinking with you. That is why what we are doing now, improving the care. We are strengthening the supervision and mentorship. We have a mentorship program that is going around. It is called Mama Samia mentorship program, if you have come across it. That program is about improving the quality of care, skills and competencies in healthcare providers. So we have realized it and we have taken care of it. We hope that we are going to improve the quality of care for the women and children of this country and reduce these numbers even more. And the question of you said something about the partners in maternal newborn health, something like that. We have policies and we have platforms to engage the other stakeholders in maternal newborn and child health. For example, in adolescent sexual health, we have NAIA, that is cross-cutting. We also involve other ministries, like Ministry of Community Development, Gender and Elderly, and the special groups. In Imtakua, that program that has been launched, we are also there as the Ministry of Health. So the issues of women and children, we know they are cross-cutting, and we get everybody on board as much as we can. I think we have brought everybody on board, including the non-governmental organization. As you are seeing here, we are discussing these issues with their partners in non-governmental organization. So everybody who is dealing with sexual and reproductive health is being taken on board. I think I've responded to your question. Thank you very much.
Thank you so much, Dr. Mzee. And unfortunately, we cannot do another round, but I would love, again, to thank give a big hand to our panelists. And I'd like to welcome now to the stage Alice Christensen. She's the country director of Jhpiego, to give us some highlights and key points from this session to wrap up. Most welcome, Alice.
Great. Thank you so much. I know I'm between you and your tea break, so I will be quick. I just have 4 calls to action from discussions with our great panelists and presenters, and also listening to all of their great presentations. But before I do that, I would really like to thank EGPAF. I think we are integrating, so Jhpiego and EGPAF both have USAID Afya Yangu programs that are integrated programs, and you can see they invited us to be part of this panel as Jhpiego, so I'd really like to thank Sajida and Roland and the rest of the EGPAF team, and show integration needs to be at all levels, including IPs. So the call to actions that I identified was Ministry of Health and P.O. Raug's leadership is continued to be needed to support and resource MNH integration. For instance, looking at reducing paperwork, which can overburden healthcare providers, and leadership is needed to look at a more integrated reporting approach, including electronic systems and investments in UCS. Another call to action, the second, is advocacy for resources at health facilities for integrated services. We need to have the test kits and supplies so that healthcare providers can go ahead and offer integrated services. Currently, the allocations of funds at facility level doesn't often match the needs for integrated services. The third call to action is for donors in the government to continue to prioritize investment in primary healthcare and using integrated service delivery models, including investment in HRH. I think Dr. Emmanuel said that this is definitely, we're seeing it more. And I think as IPs, we really are finding it very refreshing that these models of care are coming more integrated, and it allows us to align our priorities with the government of Tanzania's PHC priorities. And then finally, as all of us as stakeholders, we need stakeholder collaboration with a multi-sectorial approach to accelerate HPV and syphilis elimination by 2030. We've done very well in HIV, but we're lagging behind in HPV and syphilis. And so we have 6 years until 2030 to make sure we eliminate all 3, plus the other emerging diseases and factors that factor in. So those are our 4 call to actions that we hope you will take away with from this forum and from the Tanzania Health Summit. And again, on behalf of Jhpiego and EGPAF, thank you so much for joining our session. We hope that you enjoyed it. Bye-bye.
Thank you so much. This marks the end of the session. Welcome. Thank you again for attending, and hope you take all these action points. I would like to ask the panelists and also the other speakers to come to the stage for one last group photo. But enjoy your tea break, and looking forward to meet you outside this venue as well.
So ladies and gentlemen, delegates and speakers, this is the end of this forum. The next forum will begin at 10:30 from Deloitte Health Forum. Right now you can go for your breakfast on the last tent on your left. The last tent on your left.